Good evening, everybody, and welcome to our webinar on hormonal therapy and for women with hereditary mutations. As usual, I'd like to make this informal. I have a wonderful panel, and the panelists will introduce themselves in just a minute. But in the meantime, I'd also like to thank Dr. Taniwaki to get this all started, and Danielle Sipes for the flyer and our invitation. And of course, Beth Lynn, our nurse practitioner, who has created some of the questions and is really driving this. She has a lot of questions from our patients, from our participants. And without further ado, can I have my esteemed panelists introduce themselves? Dr. Li Mei Chen.
Hi, good evening. I'm Li Mei Chen. I'm a gynecologic oncologist. I am the division director here at UCSF and work very closely with most of the people on this webinar for our hereditary GYN cancer program.
Dr. Allison Kurian.
Hi, thanks so much for having me. I'm Allison Kurian. I am a professor at Stanford, where I am a breast cancer medical oncologist, and I lead our women's clinical cancer genetics program.
Dr. Mindy Goldman.
Hi, everyone. Thanks for having me. I am Mindy Goldman. I am a general gynecologist. I work part-time at UCSF, where I direct the Gynecology Center for Cancer Survivors and At-Risk Women, focusing on quality of life issues for either people who have had cancer or high risk. And I also work full-time as the Chief Clinical Officer for Mindy Health, a digital health company focused in perimenopause and menopause.
Thank you, Beth Lynn.
Good evening, everybody. My name is Beth Lynn. I am a nurse practitioner in the Hereditary Cancer Clinic, and I have the honor of seeing many men and women who have hereditary cancer syndromes and helping guide them through their screening and risk reduction.
Thank you. And a few words about myself. I'm Pamela Munster. I'm the director of the Hereditary Cancer Clinic at UCSF. I also very involved in phase 1 development, bringing new strategies for patients with advanced cancer. And I think the Hereditary Cancer Clinic has shown us how important it is for individuals to have really good strategies on screening and prevention, and the early recognition on who is at risk. I think I cannot stress this enough. I think the big importance in this is now that we may know years before someone develops cancer, and we can intervene early. We can hopefully prevent things, and we can impact family members. So I'm very glad that we have this webinar. And with this, I would really like to start with the first question. Beth.
Okay. So the first patient I'd like to talk about is a 35-year-old BRCA1 patient, a BRCA1 carrier, who is about to have surgery to have her ovaries and fallopian tubes removed, and she's really worried about menopause. And this is a question I get a lot in our clinic. It's probably one of the most often asked questions. So the first thing she wanted to know is, what options do we have to help this patient regarding her menopause symptoms?
Mindy, do you want to start?
Sure. So, my concern is always talking to these patients about the fact that the average age of menopause is 51. And it's a big deal if someone becomes menopausal 15 years before the natural age of menopause, not just from a symptom standpoint, which is certainly the one thing that I always want to manage for these patients, but also realizing that the estrogen that the ovaries produces protects against heart disease. And in the general population, that's the #1 cause of death. It also prevents against bone loss. We know that the most rapid rate of bone loss is in the immediate years after menopause. And we know that developing osteoporosis is a significant health problem in the elderly, because they can fall, they can get fractures, they get laid up in bed, they can get pneumonia, and people can die. And so there are significant health implications when it comes to the heart, the bone, the brain of early menopause. So if I have someone who is a healthy BRCA carrier, the first thing that I look at is, are they a good candidate for using hormone replacement therapy? Because I think we have lots of data now showing the benefits of starting people on hormones soon after the age of menopause, and that helping not just with symptoms, because we know that that's the most effective treatment for symptoms, but that it can also help in preventing against heart disease and actually lowering the risk of dying of anything. Now, that's in the general population, so we're still sort of correlating that to BRCA mutation carriers. But certainly that's by far the first thing I'm going to be talking to patients about, to recommending it unless they have other reasons that they couldn't take hormones.
And just reminding my panelists and listeners, this was a 35-year-old patient with a BRCA variant who just had her ovaries and tubes removed. So, Dr. Chen, you see a lot of these patients. We talking estrogen alone, combined hormonal therapy? Can you speak a little bit on the pros and cons?
Yeah, so we know about the pros and cons, as Dr. Goldman was referring to, from a menopausal population. As we talk about hormone replacement in a 35-year-old, if we take out the tubes and ovaries, which is the necessary surgery to reduce fallopian tube and ovarian cancer risk, that leaves the uterus vulnerable if we're planning hormone replacement therapy, in that estrogen given without progestins can increase the risk of hyperplasia and endometrial cancer. We don't want to not give estrogen in this situation, and so we do need to have a strategy of how do we protect the uterus against endometrial cancer. Different ways of managing that are with counteracting the estrogens with progestins, and progestins can be given in an oral format, in a topical format, in a intrauterine format. And so there's different strategies of how one can manage estrogen and progestin therapy if the uterus is not removed. And those would be some of the conversations that we would have in the discussion, both before surgery to make a decision about whether we do a hysterectomy or not, but then afterwards in terms of how we're going to manage HRT.
Dr. Kurian, is the discussion for you different whether someone has intact breast or has a mastectomy? Does this weigh into your discussion on which hormonal replacement therapy to use?
So I think that's an excellent question. And what really lies behind that is our questions about risk of breast cancer in these patients with giving back hormone replacement therapy. And so I would say that in general, the data are reassuring in terms of what we have for breast cancer risk. In general, particularly for women under the age of 45, taking and offering hormone replacement therapy either with estrogen alone or with combined therapy seems to be safe in terms of not typically seeing a higher risk of breast cancer related to that. And in fact, is recommended for all the reasons we heard from Dr. Goldman and Dr. Chen in terms of reducing the risks of serious long-term consequences of such early menopause. I think there is a little bit of question about breast cancer risk with starting hormone replacement therapy after age 45. There have been some questions about that. So that's something we think about a little bit. And there's also a little bit of question in some different groups, particularly in a study of women with BRCA1 mutations, about using combined estrogen and progesterone versus estrogen only. So those are the questions that come into mind. And those would be questions that would come into my mind if a woman had intact breasts, where I would have to think about or worry about breast cancer risk. If she has already done bilateral mastectomy and thus is maximally risk reduced, I'm really not going to worry very much about either of those things, and will feel more comfortable using combined hormone replacement therapy and would worry less about doing so after age 45 as well.
And to follow up on this question a little bit, do you want to comment, since this patient had her ovaries removed, how does the ovarian removal affect our BRCA1 carrier with regards to risk of her breast cancer?
It's a great question. And I would say it's been one that has had a lot of controversy in recent years in terms of how sure are we about these things. I think initially it was thought that removing ovaries early substantially reduced the risk of ovarian cancer for both women with BRCA1 and BRCA2 mutations. More recently, that's been called into question. I would say my take on the literature has been that probably overall there is some benefit. It probably is not as large as we thought, and it probably does not last as long, and it may be greater for BRCA2 than BRCA1. That's my take on it. If others think differently, please jump in.
And you mean risk of breast cancer, because I think
Risk of breast cancer.
ovarian. Yeah.
I'm sorry, I meant
Okay.
breast.
That's
Yeah.
okay. I just want to be very clear. Removing the tubes and ovaries does reduce your risk of ovarian cancer.
Of course.
That is obviously our target here.
My mistake. Risk of breast was what I was meaning to respond to.
I'll come back to the endometrial cancer in a sec. Go ahead, Mindy.
I was going to just add one thing. The used to be called the North American Menopause Society is the leading menopause organization in the U.S. They've now changed their name to the Menopause Society, but they have come out with statements that if you have someone who goes through menopause under age 40 and you are going to be giving them hormone replacement therapy, that you want to make sure you're using higher doses than you would for the standard hormone replacement therapy that you do in perimenopause and menopausal women. So that's just an important thing to note.
You're reading my mind, Dr. Goldman, because it's the next follow-on question for this patient is how do you know what dose to give of hormone replacement therapy? So maybe it's worthwhile. That will help Beth a lot as she prescribes drugs in clinic. And do you want to say a bit more?
Well, let's talk about different ways that it comes, because there is birth control pills and there's hormone replacement therapy. And traditionally, the dose of estrogen that's in HRT is about 1/3 to 1/5 the dose of what's in birth control pills. And nowadays, estrogen comes in many different formulations. It comes in a patch, it comes in a gel, it comes in oral pills, it comes in vaginal rings. And I would say first line these days is most often a patch. Part of the reasons for that is that you will avoid first pass metabolism through the liver, and that's been shown to have better impact on cardiovascular factors, as well as it doesn't impact clotting factors. And we have a number of trials, this large trial called the ESTER study, that showed transdermals do not increase the risk of blood clots versus oral estrogens do. So most people would start with a transdermal of estrogen, of estradiol, that is a bioidentical form of estrogen, similar to what the ovaries produced. And guidelines would say if you're going to be giving a patch, you would want to use the highest dose, which is a 0.1 milligram. If you're using oral, you actually use higher than that because you can go up to 2 milligrams. And then there are some people, and I'll be curious to see what others think, of whether they would give someone actually birth control pill dosing. I think most of us, once we make them menopausal, are more apt to use HRT dosing. But again, if someone is under 40, I would be starting them higher.
Dr. Kurian, Dr. Chen, any comments on the birth control versus HRT?
I guess, my thinking, and again, I'm probably the least good at this because I'm a breast cancer doctor and we are often trained to take hormones away rather than give them back. So, you all are the experts. But I think in terms of birth control pills, the things that I would worry about a little bit might be that in some cases it may be more than people need in terms of dose. Again, differs by age, and with younger women, I would think that would be more appropriate. And again, maybe people want to jump in and talk about it, but I have actually read that there may be some differences in terms of prevention of bone loss, with the birth control pill dose perhaps less effective than some of the others. So that may be something for those of you who are more expert than I to comment on.
For me, as you transition from being premenopausal through surgical menopause, it is important that taking some form of hormone therapy to start with is the most critical piece. So if people are comfortable being on their birth control pill, their cycles are regulated, they're young, and they can continue on it without any contraindication or other risk factors, potentially staying on it because that's what was working for them. And then once they've gone through surgical menopause, we've done the surgery, they're doing all right on the pill, then that leaves room for whoever's managing menopause to be able to make adjustments. So maybe that's when you change over, what the hormone treatment is. But if something's working, and especially people who like their pill, I sometimes will keep them on it with the understanding that we're going to make adjustments. Dr. Goldman, you'd mentioned, at certain ages, we want to give certain doses. But as people get older, we'll make adjustments when they're 40, when they're 45, when they're 50. So I think those are potentially like landmark times to be able to make those types of adjustments. But to me, the most important thing is they stay on the hormones, because if they're on something that doesn't work or doesn't make them happy and they stop it, then I think you really are going to you're going to look at the risk factors of menopause. And that to me would be worse than the risks of staying on the pill for a little while.
Follow-up question for you, Dr. Chen, because I'm looking at the chat. It's like, what is an ideal age for taking the ovaries out?
Yeah, so taking the tubes and ovaries out is dependent on the gene, meaning the genetic risk. We understand that certain genes have a penetrance that results in cancer at a younger age. It depends on the individual and their family history. Because it could be that somebody has a family history of individuals who have cancer at a very young age. Their mom had cancer in their 30s to 40s. It also matters in terms of where they are in terms of reproduction. So if they're done with having their kids, if future childbearing is important, then that is an appropriate reason to delay. And oftentimes we work in collaboration with our fertility specialists. If reproductive age is somewhat advancing, sometimes we want to get that conversation moving a little bit faster because there is loss of fertility after people are in their early 30s. So the guidelines currently have different ages of risk-reducing surgery depending on the gene. So the most highly penetrant gene, the highest risk of cancer, is with BRCA1. And for that, we recommend that people make a decision and consider surgery to remove the tubes and ovaries between the ages of 35 to 40. For BRCA2, the recommendation is between 40 to 45. It seems like that the age of ovarian cancer in those individuals is a little bit older, and so there's a little bit more room for some delay. And then the other genes that have lower penetrance, somewhat lower risk, RAD51C, RAD51D, BRIP1, and also PALB2, the risk of cancer is lower. Our understanding of the age of onset is that it's not that early onset. So sometimes we will wait a little bit closer to menopause. But certainly with the appropriate addition of HRT, those individuals could also have surgery a little bit younger and go on hormone therapy.
Yeah, and then last question, Dr. Kurian, is like, and we struggle with this, like, someone is on HRT and has been diagnosed with breast cancer, what now?
Yeah, that's always a tough problem for sure. And I think with a new diagnosis of breast cancer, typically we are stopping the HRT because, we do have concerns that it may have contributed or that it could contribute going forward. So that is our usual maneuver. Of course, we then have to think about how we're managing symptoms. There are many other things that we have available, and we can talk more about them, but certainly strategies for managing vasomotor symptoms, hot flashes, include medications like venlafaxine, include a new one that I've been using called fezolinetant or Veoza. Others may have had success with that as well. There is one that can also be helpful called gabapentin and some others on that list. So those are medications we can do. There are some other things that sometimes can help some people in terms of things like acupuncture, although I think the data are not overwhelming, but I've seen some patients benefit. Exercise, lifestyle modifications like that, that can be useful for the hot flashes. There are certainly other symptoms that we have to address in terms of genitourinary syndrome of menopause. Again, we can talk a little bit more about it, but we think vaginal estradiol is probably pretty safe, even with people who are being treated for breast cancer. So we can talk about that, but those would be the kind of things I'd be thinking about.
Thank you. And we have an opportunity to come back to this and go into more specific detail. So Dr. Goldman's other question, someone like me would have for you is like, oh, I've been on hormonal therapy, loving it. Do I need to get off?
Yeah. Well,
There's an end of when we stop hormonal therapy?
The old teaching used to be, this is in the general population. Again, this is not looking at specifically people who are higher risk, but the old school was take the lowest dose for the shortest duration, and after 5 years, we're worried that the risks may outweigh the benefits. And the risks were worrying about breast cancer risks in the general population. And as well as whether there were other potential health risks like negative cardiovascular effects. And we actually know now that there is this opportunity, this timing hypothesis that says if you start hormones early, that you get greater benefits. We've already talked about that, of the benefits in terms of symptoms and benefits on cardiovascular health, bone health, cognition. And if you start late, like someone's had a gap of at least 10 years, we know that that's where the risks for many people outweigh the benefits. So that's where there's a higher risk, particularly of cardiovascular disease. And no one knows exactly why, but the theories are that cardiovascular disease is related to plaques in your vessels. And if you take estrogen early, soon after menopause, before someone has plaques in their coronary vessels, estrogen changes the vessels in a way, makes them less sticky. You don't get platelets forming and all of the factors that go into forming plaques. But if you wait till someone's already been menopausal for 10 years or more, they probably already have plaques that are there. So starting late, not a good thing. There may be some tests like calcium scores that you can look and see if someone's got clean vessels. Maybe it's an appropriate thing. Starting early, a good thing. And new guidelines from the Menopause Society is if you start someone early, there is no reason to stop based on age alone. And so there are new guidelines that came out in 2017 and were reinforced again in 2022, essentially say use the appropriate dose of hormones for the appropriate stage of menopause that someone is in, and you need to reassess their health history to make sure they haven't developed reasons to take them off of hormones, but that there is absolutely no reason to stop people based on age alone.
Thank you for that. I think, Bess, back to you to our next case.
Sure. We had a 36-year-old BRCA1 carrier, had been on force, I think, and had heard that removing the uterus would simplify their hormone replacement therapy. And she wanted to know what we thought about that.
May we not take this one?
Yeah. So as I mentioned earlier, if you take estrogen when you do not have the uterus removed, there is a risk of hyperplasia and possibly endometrial cancer. There's different reasons why people undergo hysterectomy. For ovarian and fallopian tube cancer risk reduction, a hysterectomy is not required. There's some discussion about uterine cancer risk in BRCA1 and BRCA2. So starting with that, the epidemiology would say that the risk of cancer may not be higher in BRCA1, but that if an endometrial cancer were to develop, it may be in a more aggressive or a more high risk type of endometrial cancer. So some people who are trying to minimize cancer risk and are really trying to maximize their risk reduction may consider removing the uterus as well as taking out the tubes and ovaries. In terms of the hormone management, As I mentioned, if you don't take out the uterus, you do have to use progestin therapy. So if you are trying to simplify hormones, and there's some discussion, I would defer to Dr. Kurian in terms of thinking about estrogen therapy alone and breast cancer risk versus estrogen plus progestin and breast cancer risk. There may still be some differences. And so again, taking out the uterus would simplify hormones because you would not have to take the progestins, and you could be on just estrogen alone at that point.
What about progestin in just the uterus only with the Mirena or like an IUD that delivers progestin to the uterus only?
For protecting the uterus, you mean?
Yeah.
Yeah, that's a strategy that we use a lot. And in terms of our hormone therapy after risk-reducing surgery, I won't speak for Dr. Goldman, but I think a very popular strategy in our institution is to do an estrogen patch and then to use an intrauterine levonorgestrel IUD. There is probably, there's local effect on the uterus that's quite substantial. There may be some systemic effect. We were just discussing at a meeting last night with some folks who are very interested in this topic that there have been studies looking at the effects of IUD contraception and breast cancer risk. And even with the progestin IUD, there is still a small increased risk for breast cancer, probably comparable to the pill. Again, I'm going to defer to Dr. Kurian for some commentary. But it's not that we feel that there's a much higher risk. With BRCA1, you have a much higher risk. With levonorgestrel IUD, there's a small risk, but at the same time, it's an easy way to deliver the hormones. It's delivered directly to the uterus. And so I think it's still a very effective way of managing combination hormone therapy.
Yeah, I would agree. And maybe to just comment a little bit about sort of what do we know about, combined hormone therapy and breast cancer risk overall. The data really come from the largest study of postmenopausal women on this topic, which was the Women's Health Initiative. Some people may have heard of it. It started in the 1990s, enrolled a very large number of postmenopausal women who initially were cancer-free and did a few different things. There were randomized trials. One of the randomized trials used estrogen and progesterone combined hormone therapy versus placebo and basically followed people forward. The other one looked in women who had removed their uterus already and used estrogen alone. So we sort of got different data about those two things. And the thing that's been interesting in those studies has been that we do see a signal for an increase in breast cancer risk in the Women's Health Initiative, which is the general population, not people with BRCA mutations. But in that population, we did see a signal for about a 20 to 25% increased risk of breast cancer, which is not a gigantic amount. But there was that risk with the combined hormone replacement therapy. When we looked in that study at women who got estrogen alone, so E only hormone therapy, we did not see a signal for increased risk. And in fact, sort of interestingly, after long-term follow-up, there was even a signal for decreased breast cancer risk, which was sort of remarkable. In the old days, we used to use estrogen alone to treat metastatic breast cancer sometimes. We don't so much anymore, but it kind of goes along with that story. Now, what do we know about BRCA1 and 2 mutation carriers? Again, in general, the studies that are truly looking at replacement at, a 35-year-old woman, you're giving her back what you took away for 10 to 15 years, generally don't find a super high risk. But there is at least one study that I can think of that suggested that the risk was a bit higher potentially with combined than single agent. I think there was one that said that the risk with combined was about 22% of breast cancer in women who had not done mastectomy versus 12% with estrogen alone. So again, that's just one study, but gives you a sense that there may be some difference. I will say that in my practice, I don't typically recommend that people remove the uterus for the purpose of taking estrogen-only therapy. I think it's a lot to say to somebody, and there aren't really strong data to support that, nor do guidelines support that. So I would be more inclined to think about the strategy you heard about from Dr. Chen in terms of using an IUD with progestin. So at least that is relatively local, and then using estrogen patch.
Dr. Goldman, you spent many years with women who had hysterectomies, and can you speak a little bit to the to the side effects of a hysterectomy. I think
Yeah.
many people are not quite aware what it means to have a uterus removed. It always seems quite easy to think, I just want to have it all out, but this may
Yeah.
not serve a patient well.
Yeah. Before I speak about that, one of the things I wanted to comment on that some people aren't aware of, I love also using the progestin IUD for uterine protection in people who have surgical menopause, but the years that you can use it is different than contraception. So for contraception, it's FDA approved, it got extended to 8 years of use, but it's used off-label when we're using it for uterine protection for HRT, and it's only been recommended up to 5 years of use. So just so people are aware of that. I think, in
So hang
terms
on, can you repeat this? So birth control is 8 years or HRT is 8 years?
birth control, 8 years, HRT, 5 years.
Interesting.
Yeah.
What happens is that you may develop some abnormal bleeding over that last couple of years.
Exactly. The levels are sort of the absolute levels of progestin within the uterus are lower. But I always think it's an interesting thing if someone's having zero bleeding, do you need to remove it exactly at 5 years? But if you look at the recommendations, you're using it off label anyways. That's not an FDA approved formulation, so it's off label, and so it probably should be changed at 5 years. In terms of hysterectomy, one thing is there is evidence that women who have a hysterectomy have a higher risk of future urinary incontinence. We don't have, there are risks for urinary incontinence, obesity, but hysterectomy in and of itself seems to be a risk factor. And so I just talk to people about they need to think about quality of life. Issues like that, we don't have a good way of knowing who's going to develop that. We don't recommend any preventative procedures on their bladder. I don't think people used to have concerns whether there was a difference in sexual functioning post-hysterectomy, and I don't think we have good evidence that there is. Part of the difficulty in looking at that is 30 years ago, people were pretty quick to recommend hysterectomy. You've completed childbearing, maybe you're having some menstrual cramps. You don't need this uterus. And nowadays, if you're going to do a hysterectomy, there really should be a good reason that you're doing it. And oftentimes that reason that you're doing it may also impact someone's sexual functioning. So I think some of that data looking at sexual functioning is a little bit hard to tease apart. There was a nice study that looked at supracervical hysterectomy where they left the cervix because there's a thought that that may be involved in sensation and sexual functioning versus total hysterectomy, and there really wasn't a difference in outcomes. But certainly it's a bigger surgery, and one nice thing, if people don't have a cervix, so they have a total hysterectomy that includes the cervix and uterus, that they don't have to have pap smears if their pap smears have been normal in the past. So for some people, that may be a nice benefit, but certainly bigger surgery, and I do talk to people about the incontinence.
Dr. Chen, are there women where you feel strongly that they should have their uterus removed?
I think it always is a shared decision-making process. There are people who have other reasons for a hysterectomy. We don't come upon it lightly, but if someone has large fibroids, bulk symptoms, they may have pressure on the bladder, that removing the uterus may still be helpful at the time of risk-reducing surgery. People who have a history of precancer of the cervix, or other cervical disease may benefit from having the uterus and the cervix removed at the time of surgery. People who have bad endometriosis, sometimes there's adhesions that are involved with the ovaries and the tubes and the uterus. And so doing a surgery that is more en bloc may be more appropriate than trying to preserve the uterus in certain individuals. But it's a very individual situation. We typically will do an exam, we'll do imaging, we'll talk about, is it easy to leave the uterus? Is it hard to leave the uterus? What are the implications of leaving the uterus, and making sure we've addressed all of that before the decision for just taking out the tubes and ovaries.
And I think to add to this, I think since we have, I think a few patients with the carriers of Lynch syndromes, I think Lynch syndrome will be an indication to you remove
Absolutely.
the the uterus. Okay.
And I'm also going to flip it the other direction, which is, in our hereditary cancer practice, we have individuals who have frozen their eggs. Hey, they have embryos prepared. Those would be people who would want to keep their uterus after having their tubes and ovaries removed, because there still is the option of future childbearing, in the assisted reproductive technology realm. But this is where working with our fertility colleagues is really a brave new world.
And I think I want to make this clear here, because it's not that, like, you do not need ovaries to carry a child, right? You just need a uterus. And from my understanding is the uterus is a bit ageless. So there's no age limitation how long you can have a baby, not suggesting that you should take it too far out.
Yes, so the uterus is not quite ageless, and the uterus does have effects from vascular disease, for example, and things like that. But at the same time, in the world of uterine transplantation, in the world of assisted reproductive technologies, there are more people who can carry a pregnancy. It may not be the eggs have a life expectancy, and so a lot of these situations would be a donor egg scenario, or frozen egg embryo scenario for the subsequent pregnancy.
Okay, great. Beth, back to you.
So this is probably an easy one for all of you, but I have a patient who's on the estrogen patch right now, and she loves it. Her symptoms are completely controlled, but she gets an allergic reaction from the adhesive, and she really wants to stay on the patch. But do you have any recommendations on how she can manage that?
I'm happy to take that one. So there was a thought, and I don't think it's really that evidence-based, that cornstarch applied before the patch may decrease the likelihood of skin irritation, but about 10% of people will get skin irritation. If it is persistent, I will have people try things like cornstarch. I have them try it in a different location, so you can put the patch on your lower abdomen or your buttocks. It's not recommended to do both. So either you switch from lower abdomen to the buttocks, but I check to see, is it just location? For some people, the lower abdomen is a little bit more irritating. And if it really is still persistent, I'll try to change to another formulation. And I think a lot of people like the transdermal, not having to take something oral, and they don't realize that we do have other formulation. There's a gel form that you can use. And so for many people, it's what's in the matrix of the patch that causes the allergic reaction, and the gel form works perfectly fine. So that's usually the unfortunate thing. The gel one, oftentimes it's called Divigel is the trade name. It sometimes is not covered by insurance, so you have to put in prior authorizations. And then I'll also talk to people about oral meds. That's very effective. And unless someone has higher clotting risks, certainly that's a very reasonable option too.
Great. I think this is, how about the next one, Beth?
Sure. So we have a patient who carries a very pathogenic variant in PALB2, and she's considering her risk-reducing surgery, but she has a history of migraines for a long time. And she was told by her primary, I think, that she really couldn't go on hormone replacement therapy. It wouldn't be safe. Is that true?
No. So transdermals, we have good evidence that transdermals do not increase the risk of clot. It's important to realize when you have migraines, you are at higher risk for potential stroke, particularly hemorrhagic stroke. It is even higher with migraines with aura. Oral formulations should be avoided. Those people are not recommended to use oral contraceptives because there can be additive clot risks. But transdermals, the best evidence we have comes from this large trial called the ESTER trial. Again, that was looking at healthy patients, but did not show a higher risk of clot. And there have been a multitude of studies since then that show transdermals are not associated with a higher risk of clot. And we even have situations where there have been studies looking at high-risk patients. So people that were anticoagulated for having a DVT, but they wanted to make sure they got good birth contraception, and they gave them oral contraceptives while they were anticoagulated. And that, in that situation, it didn't increase the risk of clot. So we know even for that high-risk group, you can do transdermal. Migraines with aura, transdermal are okay. And then certain types of thrombophilias like heterozygous for factor V, that's okay. There's others that we just don't have data, like someone had a prior TIA or a PE. Those things, we don't have data in those subgroups, but there's certain ones, and I put migraines in there too, where transdermal is thought to be okay.
Great, Bess. Let's go to the next question, a patient with Lynch syndrome.
Sure. So I have a 42-year-old patient. It's time for her to get her uterus and ovaries removed. She has Lynch syndrome. And is hormone replacement therapy also safe for people who have Lynch syndrome? And is there any difference between the various mutations that make up Lynch syndrome?
And Dr. Kurian, this is a question for you. I think there's a bit of an increased risk in breast cancer with Lynch syndrome with some of them. I think a lot of patients may not be aware of that. Do you mind speaking to that?
Yeah, I'm happy to. And I always think it's a bit uncertain. That's sort of my take on how high do we think is the risk of breast cancer with Lynch syndrome. I think there have been some data with MSH6. Again, there have been disputed studies. I always think that it may be a little bit increased, but not dramatically so. And generally, in most recommendations, has not been high enough to say, for example, that we should screen women differently with breast MRI unless there are other reasons. For example, a strong family history of breast cancer in that family. Let me know if you disagree, Dr. Munster, but that's what I usually think of. In terms of hormone replacement, again, I would not typically be particularly concerned. Certainly, I would want to think about it in the way we think about it for people who are not at super high risk. And so I wouldn't generally be hesitant to use it if needed in these patients.
Yeah, I would fully agree with you. I think I think the hormone replacement therapy is pretty safe from breast cancer risk, as we discussed. And I don't think Lynch syndrome patients are in a different category. Dr. Chen, what about just reiterating, the uterus comes out for Lynch syndrome patients, and is there a difference in age?
Yeah, so there's a difference in the different Lynch syndromes. We know that Lynch syndrome is associated with a defect in mismatch repair, but there's different genes that can cause Lynch syndrome. And we know that the different genes have somewhat different cancer risks. In general, there's the theme of colon cancer risk and endometrial cancer risk, but some of the genes have a higher risk and some of the genes have a less high risk. In gynecologic cancers, we think about MSH2 as having a higher risk of uterine cancer and a higher risk of ovarian cancer. And the way I think about that is it's almost akin to the level of ovarian cancer risk that someone with BRCA2 has. So that's a significantly higher ovarian cancer risk compared to a gene like PMS2 that we know is associated with colon endometrial cancer, but the endometrial cancer risk is a lower risk and the ovarian cancer risk is a lower risk that's almost at the level of the general population risk, but we do know that there is an association with the gene. So how does that help us in terms of thinking about management? It relates to the fact that for many people, when you're completed with childbearing, if we think that removing the uterus is going to reduce uterine cancer risk, that becomes an option where you can take out the uterus and the tubes, but make a decision about timing and when to take out the ovaries. So somebody with MSH2, again, using that as an example, I would think about taking out the uterus, cervix, tubes, and ovaries at a younger age compared to someone with PMS2. If they're trying to reduce cancer risk, we would potentially take out uterus, cervix, tubes, but either take out the ovaries after menopause or not even perform a risk-reducing surgery if we think that the risk-benefit of the surgery is high enough.
Thank you. And then the next question I would like to pose to you, Dr. Goldman. What are our current thinking on HRT and colon cancer risk?
So there is, again, if you go back to the WHI, where we have our best data, there was a lower risk of colon cancer for people that use combination estrogen with progestin therapy. That wasn't seen, interestingly, with estrogen alone, but it was seen with combination HRT. What I don't think we know well is we're using a lot less of the progestins that were used in the WHI. So that was a synthetic form of progestin, and that seems to be the type that may have more of the negative effects on the breast. We're using more bioidentical formulations of progesterone now, and the levonorgestrel, which is not the same as the type of progestin that was studied in the WHI. And I don't know if colon cancer risks are as well documented in terms of benefits with these other types of progestins or progesterones that are used now compared to what we saw in the WHI.
And I think I just want to put this plug in. I think colon cancer screening is one of the most effective screening we probably have. We have colonoscopies, we have more DNA-based tests, and I think it's just really important for people to keep in mind this is a tumor hard to treat and probably a lot easier to prevent. So I think it'd be really important to stay on a good screening program. The questions that we haven't quite answered yet. What does HRT do to pancreatic cancer? We have a lot of patients with BRCA1 and BRCA2 mutation with increased risk for pancreatic cancer. There's some data, it may be helpful, but I think the data is not quite there yet. But it's definitely something, hopefully in the next 5 years, we have an answer what HRT does to the risk for pancreatic cancer. We have 9 more minutes. Beth, pick the next question.
Well, I'll take one of the most important questions that I get a lot. We've talked a lot about estrogen and progestin for hormone replacement, but there are some of our patients that when they have surgery done and they go on hormone replacement, they have some issues with their sex drive. And some of them come to us and ask if they can be prescribed testosterone for sex drive. And I'm wondering what you all think about how that will help and how to determine what dose to give them.
I am happy to take that. So there are groups of people that think testosterone should routinely be a part of HRT, and there is emerging evidence as to potential benefits on metabolic health, cognition, bone health, muscle mass. I would say the bone health and muscle mass, we have much better data in men than we do with women. But if you look at what is the evidence for testosterone in women, the evidence supports using it for improving sexual functioning in postmenopausal women, not premenopausal or perimenopausal, but in postmenopausal women. And there was actually a large expert consensus group that got together in 2018 to sort of look at all of the evidence, and that's what they came up with. They also came up with guidelines as to how to prescribe testosterone. So some of the problems are testosterone is considered a controlled substance. And so it has to be, there are laws that differ in every state about controlled substances, about how often you need to be seen to get a refill of that medication. Only certain providers have appropriate licensure for giving controlled substances. When you give testosterone, there are guidelines for measuring testosterone levels, free, total, sex hormone binding globulin before you start someone on it, and how often to check afterwards. And there are guidelines as to what range that you want to keep someone's testosterone level, which is in the normal premenopausal range. So you want to avoid getting too high levels so that someone doesn't get androgenizing side effects like acne or hair growth. So there are guidelines that can tell people how to prescribe it. I would say for premenopausal women, so we have FDA-approved drugs for low libido. One is called flibanserin. The trade name is Addy. The other one is called bremelanotide. The trade name is Vyleesi. Those may be covered by health insurance, and they are FDA-approved in premenopausal women. Testosterone, although it will help sexual functioning, you have to jump through all these hoops because it's a controlled substance. And it really is more beneficial in postmenopausal women. The other drugs you can use in postmenopausal women, but they're off-label and they have to be obtained from specialized pharmacy. So long explanation, but yes, it can help out with sexual functioning.
Dr. Kurian, how do you feel about testosterone, the risk for breast cancer, or in someone who had breast cancer?
Yeah, that's always sort of I guess, again, I would say controversial topic. And I think we tend to be a bit conservative from a breast cancer perspective and prefer maybe other options if we can. I don't think the evidence is compelling for a significant increase in risk or a substantial increase in risk. I don't think we have any good data in women with PALB2 or BRCA1 and 2 mutations. That's my 2 cents.
Yeah, and definitely, I think in someone who had breast cancer, I'm quite reluctant to prescribe any testosterone. It's like probably not for a lot of good reasons, but we don't have good safety data, and I think so. I think
I've never prescribed it in a breast cancer survivor. I think it's a question of what about somebody at high risk? Do we think it's a problem? Again, I don't think we have much data there, but.
So Bess, do you want to take on one of the breast cancer question?
Sure. So we have a patient who has BRCA2, and she has a recent history of a hormone receptor positive breast cancer, an invasive cancer. And she's completed treatment. She's on tamoxifen to reduce her risk of reoccurrence. She's been told by her oncologist that she can't use hormone replacement therapy, and she understands that. I think you talked a little bit before about what other medication she can take with hot flashes, night sweats, and also, is it okay for her to take vaginal estrogen for all of the changes that happen post-menopause in the vagina?
I can touch on that if useful. So I had spoken a little bit before about non-hormonal treatments for hot flashes, for things like that. I think we have this new interesting drug, fezolinetant or Veozah, that has been shown to have a significant reduction in hot flashes. This works by a different mechanism than hormones. It is basically a neural mechanism. And because of that, I think that could be a good option for people. I don't think there's any concern about cancer risk. This is something where, again, I've had several patients have a lot of benefit from that. There was a recent study published of another one of that class, and I'm going to say it wrong, but I think it's elinzanetant. Anyone who knows how to say it better, please let me know. But also looking very promising in terms of options for our patients. I've had a few say that it really was game-changing for them to try the fezolinetant or Veozah. But other options are certainly the gabapentin as an option there, venlafaxine, another good drug that one could try for those things. I think this question of is vaginal estradiol safe in patients with breast cancer, we all worried about that for a while. I thought there was a very good study about that a year or so ago that came out of the United Kingdom. I believe the first author was McVicker. I think it was in JAMA Oncology. And that was an observational study in the United Kingdom where they have really good records and they have basically universal coverage of healthcare there. And so they know who's taking what. And in that study, I believe they looked at women who had breast cancer, who were receiving vaginal estradiol, and they did not see a signal for an increase in death or other concerning features in terms of breast cancer that way. Now, I don't think that study specifically had recurrence as an endpoint. It's always harder in population-based data, but at least in terms of the more serious outcome of death, they did not see anything. So I found that somewhat reassuring.
Can I just add a couple things? What's I think really exciting with first of all, I tell patients like this, no one needs to suffer. There are always, always, always things that we can do. Before fezolinetant came out, all of these other drugs we didn't really know how they worked. All we knew is that they cross the blood-brain barrier and they affected some temperature regulation zone in the brain. And we take advantage of the side effects of those drugs in deciding which ones to use. So gabapentin causes sedation. So if they're having their hot flashes at night, we'll use that. One is oxybutynin. It's an overactive bladder med. So if someone is having hot flashes and a lot of urgency and frequency, we may use that. Because Linnetent is the first drug where we actually understand this mechanism of how it works. It is a neural drug. There are others in the pipeline. The only problem with this is this just came out last week. There are some reports of some liver toxicity, and the FDA just changed their recommendations, and people are supposed to get liver functions at baseline when they start, and then every month for 3 months, and then again at 6 months and 9 months. So for some people, it's a great drug, but for some people coming in to get those frequent blood tests may be something that's a little too much for them. And then it is important to note that in the trials that led to its FDA approval, they had excluded cancer, but we're most interested in using it in cancer survivors. And there's nothing about it that's hormonal that would suggest it should be a contraindication.
And yeah, you know, for someone who's done clinical trials forever, right? It's like every hormonal manipulation can cause liver function abnormalities. I think one should still be mindful. Is there a chance that someone has undiagnosed hepatitis from a viral, from a hepatitis C virus or hepatitis B virus? It's like it's just when you start talk to your doctor about other things. I mean, clearly, if someone uses excessive alcohol, the risks are higher. I think I know why alcohol is a challenge. And then I think what's really going to be interesting and exciting as we have finally drugs that help with obesity, which is a common problem in the world. It's like these drugs will have interactions, and I think it'll be really interesting to see what's going to happen. It's going to happen here. We are at 6:31. I'm gonna start screening a little bit through the chat. And James Pegler, right? I'm a 41-year-old CHEK2 mutation carriers. I've heard different options from my oncologist and my geneticist. My oncologist recommends hormone replacement therapy. However, my geneticist said there's any proof HRT would reduce the risk for CHEK2 and it could increase the risk of uterine cancer. What are your thoughts on these two different opinions?
So I guess looking at this, I'm a little bit confused, and Dr. Munster, maybe you can help me think about it. But with CHEK2, we don't worry about ovarian cancer risk or uterine cancer risk. So I'm not quite sure why this person of 41 would have these symptoms. And so that would just be something to bring up there.
Yeah, the Dr. Chen, we don't routinely recommend oophorectomy or CHEK2 mutation. So I don't think that should be a concern. And I think if you have a CHEK2 mutation and you're postmenopausal naturally, I think hormone replacement therapy should be allowable, right?
I agree. I think it's important, again, to recognize that different genes have different risks. We're still in the evolution of understanding the amount of risk. Some people may have been notified recently that for PALB2, we are considering the role of risk-reducing surgery. For CHEK2, we still do not think there's a significant association that oophorectomy or tubes and ovaries need to be removed for CHEK2.
But there's a couple of questions that I see that I feel we may have answered already, and answering them and ask you to write in again if you feel like we haven't answered it completely. So I'm not trying to avoid questions, but some of them we have gone in a bit more detail. I have a CHEK2 mutation. I'm 49 years old. Both of my breasts and no diagnosis of cancer. However, both my sisters were diagnosed with breast cancer at 46 and 48. a double mastectomy 6 years ago. Would you recommend I take hormones now for perimenopause or not? Dr. Kurian.
So again, I think it's always a bit of a question when we have family history and we have CHEK2, right? These are both risk factors. I don't think either of them are hard contraindications for HRT, but I will say that I am a little bit more cautious in just sort of wanting to think carefully about that for these patients.
Yeah, I would probably agree with you and maybe go even a little further. I think this is a person who probably really needs intense screening
For sure.
for
CHEK2,
breast
for
cancer.
sure.
For CHEK2, and we don't have
Yeah.
like recommendation for risk reducing surgeries that are very clear. But this is, I would think, someone who could really benefit from either seeing us in clinic or seeing you in clinic at UCSF or seeing you at Stanford.
I agree. And I would say that breast MRI screening is a standard of care for people with a CHEK2 genetic
Absolutely.
mutation. Yeah. Supported by guidelines, covered by insurance, should be done.
So I think, Dr. Goldman, what would you start HRT at? It's like, this is perimenopause. Would you still do a 0.1 patch, or would you do less?
Yeah, there's no absolute recommendations in the normal age of perimenopause, which is, the average length of perimenopause is 4 to 6 years. So anyone who's 45 or above, I generally will start middle of the road patch so that I can go down if someone seems to be having side effects, or up if they're not having full alleviation of their symptoms. I'm always worried about starting too high. So I generally would start in the middle of the road, which is a 0.0375 patch, and then you can go up or down from there. Some people would probably start a little bit higher, 0.05, if she had completely normal periods. But if her periods are starting to space out, overall estrogen levels are probably lower, I would use a little bit lower patch.
Okay. How long should one stay on HRT to have it be effective? I had oophorectomy at 44 and used the patch until 49. You touched on this a little bit.
Depends, what do they mean by effective? So if it's for symptoms, we know that there are some people that the symptoms are like 80 to 90% of people will have vasomotor symptoms during that menopausal transition. And if you follow people, there are a number of people that the severity of the symptoms decline even without any treatment. That doesn't mean they may not have a hot flash or a night sweat now and then, but not something that's so bothersome. So it depends on if you're talking of severity of symptoms. It may be if symptoms were bad, you stop hormones, she's going to get a resurgence of those symptoms. If you're talking about it from the cardiovascular benefits and the bone benefits, I would say longer is probably better. We don't know as much with the cardiovascular, but certainly bone benefits we know.
Thank you. Next question is for Dr. Chen. My BRCA1 care, I've taken the BCP for 5 years. Does this allow me to postpone taking my ovaries and tubes out because I've reduced my chances of ovarian cancer with PCPs?
Yeah, we have data in the general population about oral contraceptive pills decreasing ovarian cancer risk. The longer you use it, up to 5 years or more, can decrease the risk of ovarian fallopian tube cancer by up to a half. In the BRCA population, there are studies that suggest that that is also possible. There are also studies that say that there's not a higher risk for being on the pills for a longer period of time to a significant amount. In terms of, does that allow you to postpone taking out the ovaries and tubes? I'm going to assume that this person is of the age that we're talking about, taking out the tubes and ovaries. I think that we don't have that information to say that that would be a recommendation. I think we would still follow the guidelines and talk about ages 35 to 40. That range is there so that people can have some leeway, some conversation, some discussion. Really, the risk is that after age 40, the risk of cancer starts to increase And even after taking the pill, I think the risk still starts to increase. So it's a relative time frame of when we would consider risk reducing surgery. I think that, in terms of, do we think that there is benefit? There probably is some benefit, but there's also the difference of, does this person still have their breast tissue and have they had a mastectomy, to see how the OCPs affect their breast cancer risk as well.
Thank you. So the next question is, I think we talked a little bit about this. It's a 51-year-old patient with lots of symptoms of menopause, strong family history of ovarian cancer, and CHEK2 variant with elevated risk for breast cancer. Should I start HRT now, or when I do the mastectomies and oophorectomies in a few months from now? Lime?
So it's interesting because you said this is CHEK2, which we don't think is significantly associated with ovary cancer, but there is
a family history of
I was just
ovarian
about to
cancer.
say,
Okay.
but there's a strong family history of ovarian
Yeah.
cancer.
Yeah.
And so in someone who is menopausal, I think that this is a slightly different conversation of, we're not necessarily doing it specifically for the gene, but more because we think that family history does confer risk. So I do think that there's a role in a shared conversation. And after menopause, I think some of us would talk about taking out the tubes and ovaries for somebody with a strong family history.
Would you start hormonal therapy now, or would you let her suffer a little bit longer?
Again, as we said, no one needs to suffer.
I know, it's like I was looking at Dr. Goldman, who is my neighbor and doesn't want anyone to suffer. It's like
right. So she could be managed for menopause even as she's talking about, when to have her ovaries and tubes removed. So manage the menopause and then consider like the timing of the surgery.
And I think this is really something we want to get across here. It's like, you do not have to wait for HRT until your surgery. This should be managed when you have symptoms. Would you agree, Doug? Can you weigh in a little bit more on this, Dr. Goldman? It's like
Yeah, actually, that brings up a lot of people wonder, do they also have to be menopausal to take HRT? Because I think, if anything, the perimenopause may be a more confusing time because people are still having cycles. They may not be regular, but they can have all of the same symptoms that you see in menopause, all of the temperature dysregulation, mood changes. You tend not to see as much of the vaginal symptoms, but sometimes palpitation, joint pain, brain fog, sleep difficulties, all of that, but they're still cycling, so they're confused and wondering what's going on. And we don't have evidence that says you can't use HRT in those patients. What is important for people to realize is, because HRT doses are only 1/3 to 1/5 of what's in an oral contraceptive, HRT will not suppress ovulation, meaning if someone needs contraception, it's not going to be sufficient. It will not provide contraception. As well as sometimes in the perimenopause, people have abnormal bleeding, and HRT is not going to fix abnormal bleeding. So if someone has abnormal bleeding along with their other perimenopausal symptoms, we'd be more apt to give something like a birth control pill, which may take care of everything. But people can use HRT during the perimenopause.
Hey, Dr. Kurian, anything good that you have at Stanford for brain fog for your breast cancer patients?
I don't have anything magic at Stanford, I'm sorry to say. I think it's a challenging problem, right? And so again, what is the cause of brain fog here? And, can we really attribute it particularly to menopause or to other things? I would defer to Dr. Goldman and other experts here in terms of what you think about that. I think certainly there are some patients who feel better on HRT, certainly. I think if somebody has breast cancer, we can't do that, right? So there are lots of questions in terms of where things are. Often I will ask the patient if there are other things that maybe we can optimize. So occasionally I'll have patients who are waking up all night with hot flashes, and sometimes if we can make that better and people can sleep better, they notice a bit less brain fog. That's been something that I've experienced. But again, I would defer to the group a bit in terms of their thoughts about whether brain fog per se is a result of the change in hormones?
We know it's definitely one of the perimenopause and menopause symptoms. It's a common one. And so why it happens, I don't know if people really understand that. I always approach this of fix what you can fix. Certainly, if someone's a candidate for HRT, that's great, and we can see if the brain fog resolves. But there's other things to address. The incidence of sleep apnea goes up after menopause. So really addressing what's someone's sleep. What's going on? Do they need a sleep study to rule out sleep apnea or a restless leg? What's their mood? We know mood disorders is also going to affect your brain functioning. It will affect cognition. It will affect brain fog, thyroid disease. So I think there's diabetes. We look to see, do people have diabetes? What's going on from a metabolic standpoint? So certainly hormones are great if they are an option, but in breast patients, for example, who are on all these other adjuvant hormonal therapies and HRT isn't an option, you sort of fix what you can fix and, approach all these kind of in a very holistic way. And then I'm a big believer in all of the integrative stuff, really talking to people about their diet, their exercise, things that they can do, cognitive behavioral therapy. We have evidence for cognitive behavioral therapy. It's called CBTI for insomnia. There's randomized control trial evidence. So I think that there can be many, many things that contribute to brain fog that we can address even when HRT isn't an option.
I also think I want to address a little bit is particularly in patients with breast cancer. Breast cancer diagnosis is a huge trauma, and I think having a post-traumatic stress syndrome from the diagnosis can very clearly impact cognitive function. I think just I think if you have a diagnosis of breast cancer, be kind to yourself, recognize how much of a trauma this is. And I think cognitive behavior therapy, having any therapy, having any support, and just recognizing this is a very significant trauma, like any form of cancer is. A diagnosis of a BRCA mutation can be a significant trauma. I think don't try to tough it out.
That. I'm sorry, you go ahead. I just wanted to agree. I agree so strongly that that's the case. And I've seen it so many times in patients with clearly what I think is PTSD in terms of intrusive thoughts. And again, being sort of numb to it all while they're getting treated with chemotherapy, but after they're done, all the feelings rush in. So I didn't mean to interrupt you, Dr. Munster, but I just couldn't agree more.
Oh, you didn't interrupt. It was just what I try to say, like, don't tough it out. Is like it's very striking, and I tell all my breast cancer patients for the period of about 18 months, there's this sense of like you have just lost your immortality. And this is really hard to describe to someone who's never gone through this, what this means if you all of a sudden feel this profound vulnerability and so, and I think, and then compounding this with not being able to sleep, having hot flashes, being hot, is like, I think, yeah, and I would totally agree with Dr. Goldman. Fix what you can fix, anything we can fix. And please speak out is like, we can find a solution. I think going back is like, I mean, if you have vaginal dryness, when you have breast cancer, we can probably find something. Dr. Chen, does birth control reduce the risk for peritoneal cancer?
Well, we believe that ovarian, tubal, and peritoneal cancer are the same disease. What we don't know is kind of where specifically the peritoneal cancer arises, other than a cell in the peritoneal cavity. So I'm not sure we have specific data for peritoneal cancer independently of ovarian and fallopian tube cancer. But I think that from a risk-benefit standpoint, there probably is an overall benefit. It's just hard to quantitate. I would not recommend that someone takes birth control pills to decrease peritoneal cancer risk after having tubes and ovaries removed, however.
Thank you. And then Dr. Kurian and maybe Dr. Goldman, if someone has triple negative breast cancer, can they have HRT? Do you feel good about allowing HRT for the triple negative breast cancers?
Makes me nervous. Just to be honest with you, it makes me nervous. So I think it is debatable. I think various things come into play. I think it comes to questions of how significant was this triple negative breast cancer? How long ago was it? Right? All those kinds of things. I think it might be a question also of how severe are their symptoms, right? So if this is someone where you have tried absolutely everything else to manage their symptoms and they are still uncomfortable, then I feel differently. But it always makes me a little bit anxious in breast cancer survivors. I'll say that.
Yeah, I would agree with that, and I think the same holds true for testosterone. I don't feel
Yep.
like because we see a lot of patients have a lack of sex drives. Like Dr. Goldman, how do you feel
Yeah,
about
I
that?
know that the literature is mixed.
Mhm.
I think I feel a lot more comfortable when people are 5 years out from a triple negative cancer, because it's not the same as a hormone positive cancer. And I think of those people
Mhm.
at least of being cured from that cancer. Anyone who is less than 5 years, I will always have shared decision making, not just with the patient, but with their oncologist, because they're going to still be followed by oncology. So it depends on how severe the symptoms are. But I know after 5 years, if people are discharged from oncology and they're back to general GYN or primary care with shared decision making, I will oftentimes offer HRT at that point.
I agree. I would say I only, just because for those of us who have been treating breast cancer for a long time, I have a little bit of fear. I mean, I would love it if 5 years was always a hard line, and I just, it makes me a little anxious. Is all I would say. I've occasionally seen late recurrences. Is just my 2 cents.
What about the 72-year BRCA2 carrier using baby time for chemo prevention? Could I use something like gabapentin for the hot flushes that have returned since I'm using baby time? Dr. Kurian, you want to talk a little bit about baby time? This is coming up a lot lately.
Sure. I'll be happy to. I guess let me the one thing I noticed that I just wanted to comment on first is taking tamoxifen for prevention at the age of 71. And I bring that up because, again, I think often we feel like the risk benefit ratio of tamoxifen often becomes less favorable after age 65 or even age 60, right? And so, again, what is the residual risk in somebody at age 71? I might be hesitant to be thinking at all about chemo prevention. So let me just put that there. And I'd like to hear other people's thoughts. But in terms of baby TAM, for years, we've had really good data on full dose tamoxifen. We've had multiple trials that have shown that taking full dose 20 milligrams of tamoxifen for 5 years does reduce risk of developing breast cancer. And there seems to be a long-term protection. It's not just those 5 years, but in most trials, seeing a persistence of risk reduction after that. But of course, there are various side effects and can be more serious risks, such as an increase in risk of blood clots and of uterine cancer with full dose tamoxifen. More recently, there's been a trial called the TAM-01 study out of Italy that looked largely at women with things like DCIS, atypical hyperplasia, did not, to my knowledge, specifically look at genetic mutation carriers. But again, in the people it looked at, did see that at a lower dose, baby TAM, 5 milligrams or a quarter of the full dose taken for 3 years, at a total of 10 years follow-up, they did still see a significant reduction in breast cancer risk of around 40-ish% reduction in risk. So, and again, with much fewer in the way of side effects, did not see any blood clots, did not see any uterine cancer. There's some evidence that this low dose seems to be more effective in postmenopausal women versus premenopausal women, though again, need longer follow-up and probably larger numbers overall to look at this option. But I think in general, it can be a good option for postmenopausal women who are thinking about risk reduction. That being said, again, 71, I sort of doubt the risk benefit profile here.
So you would recommend probably there's not a lot of benefit for someone who's 71 with tamoxifen?
That's my question. What do you think, Pam? Dr. Munster?
I'm struggling with this because I think it becomes a very individual question, right? Because how long is what's the expected life expectancy? If you take a 71 who's going to live to 105,
Absolutely.
that's a lot of years where you could develop breast cancer. If you are very easy to examine breasts, then patients willing to go to MRI and mammograms just a lot of MRIs and mammograms over another 30 years.
Right.
So I think it becomes a good question. I'm still a bit nervous with someone with an intact uterus with any form of tamoxifen, because the risk for clots, the risk for strokes, the risk for endometrial cancer with tamoxifen, even if you do a lower dose, it's like it's not nothing, and we don't really know exactly what the risk. So I think, Allison, we should really focus a lot of our BRCA research on the more mature woman, because I think we have a very good handle on what to offer a 35-year-old who has 50 years of breast cancer prevention, right? Where like surgical intervention may not be such a difficult choice, but we see more and more patients in the late 60s, and same going to you, Lile, is like, do we take the ovaries out to someone who's 71? Because it's not a huge surgery, and risk of ovarian cancer is something we see. It's like, what do we do?
It's a really individualized question. If somebody is healthy and has no prior surgeries and wants to do it, I think that's appropriate. It becomes a question of, at some point, that there's probably an inflection point, but it's going to be different based on the individual.
Can I add one thing about the tamoxifen? In the trials that have looked at uterine cancer, the uterine cancer risks have largely been confined to women over 50, so mainly in menopause. And that's because tamoxifen is thought to act differently in an estrogen-rich versus an estrogen-poor environment. So I've been really excited about the baby TAM dosing, particularly for my postmenopausal women who I think the uterine cancer risks are greater with tamoxifen, with full dose.
Yeah, and I'll just say that I think we lack the data that we would like to have for people with BRCA2 mutations and tamoxifen in general. I don't know of any data for baby TAM. I think it's a reasonable thing to do, but I don't know of data.
I mean, there's a lot of it is extrapolation, so I don't think we know. And and I do feel like what we really need is data in the older men with BRCA mutations, because they're like other mutations, because we never really had that problem, right? We never tested anyone. People got tested when they were diagnosed with young cancer, so this is different. So I think we almost at the end there. I had another question that I thought I should bring up. Let's see. Dr. Goldman, can you go through the Mirena again? I think I know you said it, but we were to get the data for the Mirena and the expiration again, if you don't mind.
So the levonorgestrel IUD, or the Mirena, is FDA approved for contraception. And when it is used, they just not that long ago extended the effectiveness for contraception out to 8 years. It is used off-label for HRT, for protecting the uterus. When someone has a uterus and you're giving estrogen to protect the uterus from uterine cancer. The recommendation is 5 years. Now, you can argue theoretically that doesn't make sense, because you have enough hormones in there that you can protect against contraception, although it's not probably all hormonal. Some of it is just mechanical, but it protects against contraception for 8 years. But we just don't have the studies looking at it yet, such that the guidelines are, when you're using it off-label for HRT, you should change it at 5 years.
Okay. Last question for Dr. Chen, and this always comes up. What about removing the tubes before the ovaries? What's new on that question?
Great question. I think that we believe that these cancers frequently develop from the fallopian tubes. We also know that there are cancers that develop in the ovaries, so taking out the tubes isn't enough. I'm looking at the question from the last attendee that says they're BRCA1 positive, they're done having kids at age 31. Should I have my ovaries and tubes out and do HRT vis-a-vis this webinar? The risk of cancer at age 31 is not that high. The risk of menopause at age 31 is considerable. We can give HRT, but we've talked about many challenges and the things that can be associated with HRT. So taking out the tubes or a salpingectomy might be an appropriate interval procedure for this 31-year-old who is done with childbearing. Where's the data? The data are in the populations that look at where tubes have been removed. There seems to be less high-grade serous cancer. The studies are currently ongoing, and we have an open study that's looking at comparing the outcomes of salpingectomy, taking out the tubes, bilateral tubes, versus taking out the tubes and ovaries, the BSO procedure. That study is going to take 10 years to complete. We're about a quarter of the way through. And the outcomes that we're looking at relate to cancer risk, relate to subsequent surgery, relate to menopause and quality of life outcomes. So I think that there probably is something there. It's just that we can't really quantify it or really make a recommendation at this time. And so that's why the recommendations are still tubes and ovaries, but for appropriate clinical scenarios, taking out the tubes probably does make a difference. It's just that we can't make that as our formal recommendation for absolute positive maximal benefit for cancer risk reduction.
Thank you for that. And with this, it's 7 o'clock, and as usual, we have like more questions than we could answer. The webinar, it will be posted to our website, so you can look at it. These webinars are every 2 months, so we try to come up with a topic that is timely and help our patients, family members, and panelists. I can't thank you enough. It's always so much to learn. It's like really exciting to have you speak on this, and I hope it was not too onerous with preparations. And so, Bess, thank you for your incredible work in the BRCA and Hereditary Clinic and putting these questions together. So with this, I think we end here.